Okay, we are trying to do the images, take the images. It's a 6 French guide catheter because it's just isolated LED and not very heavily calcified. We thought we'll go with a 6 French guide catheter. Okay, we'll take a long run.
Okay.
Can you have an RAO tilt? RAO wave. Yes. Okay. I think we'll try with an imaging catheter. If it crosses, we'll do an image first and then go ahead with the rest of the things. If it doesn't cross, we'll go with a Viper catheter, Viper wire, and then do the OCT, do the orbital atherectomy. So,
Dr. Deepak,
yes.
even though the catheter cross, can the lens move? Because of tightness, the force is sufficient to move the lens?
Mostly, yeah, the lens will invariably move because it's inside that sleeve. But then
force is not sufficient.
it almost always moves. But then what happens is the image may not be good because you do not have a contrast penetration beyond their critical lesion.
Yes,
so image will not be good. But at least we'll get an idea. We get to know what exactly is happening proximal to that very critical stenosis, in case it crosses. Thomas, we'll go with a wire. Okay, get the OCT catheter ready. Thomas, we have Dr. Thomas here with us. Josie, Dr. Thomas is here with us. His history is he had an infusal MI. I think it was almost 2 weeks ago, right?
Yeah.
2 weeks ago, that circumflex was stented. It was occluded. It was stented then, and now for the stage procedure.
Diabetic hypertensive with multiple renal tumors operated in 2013. Nephrectomy was done.
Did you hear that?
Yeah, we can able to.
Yes, yes. Nephrectomy was done few years ago.
2013.
2013. But is creatinine?
Creatinine is 1.2.
Yes, it is compensated.
Yeah.
RAO crane? We'll come caudal once again. It's inside the different, more of spider. Oh. Be ready with another better wire. This is an ox wire. Okay, we are into LED. Okay, now come cranial. The side branch. Side branch. RAO cranial.
Septal,
no? Septal. Yes. We are in LED. Yes. Okay.
One more lesion down.
Down there. I think we'll stent. And then. Okay. Now we try to cross with the OCT catheter. Mostly it might not go through. Okay. OCT catheter. 20 cc syringe. Okay. Image on. Show us the live image. OCT image. Do auto calibration. Fisheye. Okay, fisheye. Okay, auto calibrate. Okay. centralize. We are not seeing the catheter. Even if the distal half crosses the lesion, many a times the proximal lens marker, it wouldn't cross the lesion. Okay, it's not crossing, so okay, it's almost crossed. Okay, we'll keep it there. Okay, then we'll do the OCT pullback. Okay, the lens would run backwards without any difficulty, but then the image at the second half, the distal half, may not be good. Okay, we are ready. Guide is in position. Yes. Yes. Auto calibrate. Enable pullback. Yes. Activate. Okay, now the microcatheter and the wiper wire.
You can see the eccentric calcium actually. Eccentric calcium.
Microcatheter അകത്തോട്ട് ഇതിന്റെ പുറത്തൂടെ അങ്ങ് push.
Microcatheter.
Give a 7.5. Vishnu, can you take a mic and explain the OCT images? Can you give a roaming mic? Arya, show the distalmost portion. Okay, there we are not seeing the image properly because of contrast. Penetration was not there because of tight lesion. Now, okay, Vishnu, frame by frame, proximally, can you just explain?
This is a distal. No.
Microcatheter.
This is a distal portion.
Now the wiper wire.
Just distal to the lesion, tightest lesion, and the minimal lumen area is 1.35, and there is some.
Can you hear us?
Yeah.
Okay.
Eccentric calcium is there, deep calcium. The tightest point is area is around less than 1.7.
Yes,
There is some more than 180-degree arc of calcium. Superficial and deep calcium present.
Catheter tight lesion.
Tight lesion.
Ah.
Then after that there is eccentric calcium. Then there is calcium nodule is there. Just after the branch. Then there is a 360-degree arc of calcium.
Yes.
And proximally there is good lumen. LMC is normal. Left vein is normal. And sarcostium also disease free. Proximal LAD also. Ostial LAD also disease free. Proximal LAD, fibrotic lesion of the ostial LAD, and the vessel size at the ostium is.
Actually, the eccentric thick calcium under 270 degrees calcium is there.
3.5.
Any microcatheter എടുത്തേക്കാം. Okay, now we have the wiper wire inside. We'll take out the microcatheter. Okay.
What is the vessel size here?
Approximately it's more than 3.5. Distally we are not able to identify that.
Because of disease.
Yes.
Proximal also you have to cover. Ostial LAD. Up to ostial LAD you have to cover.
Vishnu just shows the tightest area that calcium there appears that area there appears to be intimal calcification. Few frames distally and for backwards. There it's more of intimal. Few frames that area it appears to be intimal, and few frame backwards also.
These are the patients maximum benefited with ablation.
Yeah.
Now we can see the appearances after cuts. This is a design image. Gutters like you can see. You can appreciate it post atherectomy.
Okay, now we'll go with the orbital crown inside the coronary. Before that, we are checking. Can you show the live images and fluoro monitor? Okay, fluoro and live picture in picture. Camera picture in picture. Show us the table picture in picture. Okay, now we are checking all the parameters. We have a good saline flow. We are locking the brake, and then trying the orbital. It's working. We have kept at 80,000 rpm. Then we are freely moving the advancer now forwards and backwards. We are able to do that, and then again we'll release the brake before we go into the coronaries. Exactly like rota. Now we are almost reaching near the lesion. Once we are near the lesion, you could see that it's gone in. We have taken a New York catheter, a 6 French guide catheter. It's gone in without any difficulty. Unlike the rota wherein we find it difficult to get the sleeve and the burr inside, it goes in without any difficulty. Now we have reached near the lesion. So we are at 80,000 rpm. The lock is on. Now we'll do the burring. It's a very difficult lesion. It's not moving forward.
Slowly moving.
You would have appreciated the change in pitch as it was hitting against the lesion.
Yes. I think maximum benefit will patient get with atherectomy in this
scenario. Yeah.
Case.
Yeah.
That's why uncrossable lesions they will get more benefit primary orbital without any balloon.
But if you keep looking at the image, you almost always have the burr jumping across the lesion. As you keep watching the image,
your movement is relatively more powerful. Your forward movement is more powerful than the burr movement.
no, the area where you have the maximum. Now you've seen that, right? Area where you have the maximum amount of calcification, intimal calcification. That's the area it gets stuck, and at some point of time you need to do a judicious push.
No, Deepakji.
Yeah.
It automatically, if you do the axial movements, very dead slow movement, actually you won't appreciate also its movement.
True.
Very nice, actually. You demonstrate that ablation at the maximum thickness site.
You could see that it just jumped this time also.
Yes.
Now this time we'll do the retrograde.
Yeah.
Many times when we do retrograde also it jumps at that particular which means that you haven't ablated it properly. The jumping forwards and backwards when it happens, we sure that there is significant amount of calcification. Still you can do further more work on that
You can park at that watermelon seedling effect, like
Yeah.
narrowest portion and
Yeah.
per it, that's all. As much time as possible you can spend there.
30 seconds. 30 seconds. When we did retrogradely, there was no significant change in pitch, but then we felt that there was a small jump. If you can slowly keep watching that crown, yes, there we saw a small jump. Now we'll again try doing slowly forward and backward. Here again almost 30 seconds.
If you carefully see, you appreciate the thickness of the it is coming down. If you carefully see the diagonal side of that calcium thickness is slowly coming down. When you see, appreciate, thick calcium become thinner and fading out like.
You are trying to say that as you grow older and older, the visual acuity improves, is it?
Yeah.
Josie, would you agree with that?
No, actually, even with IVL also we have seen this phenomenon.
The thickness it.
Thickness will come down because it become pulverizes.
Uh-huh.
Once you prostrate, then the thick calcium become thin calcium.
22 seconds, 25 seconds.
Actually, if you do stent boost,
We are
you can appreciate better.
again 30 seconds.
You can appreciate better with stent boost. Now you are giving a new point at the tip and trick. Till the jumping movement disappears, you have to bury it.
Yeah, this jumping, that's what we do in this tightest areas. Most of the time retrograde as well as antigrade it jumps, but at some point of time this jumping stops. We are sure that at least reasonable sanding has been done.
Sound, jump, gutters.
ഇത് ഞെക്കിയിട്ട് സ്ലോ മൂവ്മെന്റ്. This time also we saw a small jump forwards. Backward. Backwards. Okay, we'll stop. Back to. He doesn't have much of angina, that's why we're keeping it distally inside. In case he develops angina, definitely we'll bring it back. Again, the waiting period is only 30 seconds. Okay, we.
Calcific, Deepak ji. Even
Yeah,
distal
yeah,
tight
that's-
region also
yeah,
you
that's
can ablate it,
30.
sand it.
Yes.
Calcium is proximal to
അവിടെ
tight
തന്നെ
region.
കുറച്ച് ഫ്രണ്ട്. ട്രൂ, വെരി ട്രൂ.
As you increase the burst speed.
Now next we'll increase the burst speed. Stop. Now we have done few runs. Now there is no significant jump because it's more than 3 millimeter vessel. We'll go up to higher speeds and then again do antigrade and retrograde. 16, 17 seconds. We'll wait till it's 30 seconds. But with rota, we are very meticulous that we'll always wait for 1 minute at least before we go with the second run. We'll do one retrograde, then once more, and we'll stop. Once again, നമുക്ക് പോയിട്ട് antegrade once, retrograde once, and we'll stop. Even now we could hear some pitch changes, but probably this is almost 10 times we've done.
Intensity came down.
Intensity has come down. The pitch change is different. Moreover, I feel that, as you have told, my visual acuity is also improving. That calcium area appears to be less.
Yes, yes. No, you can see the
Yeah.
density of
Yeah,
calcium
then she appears to be less. True.
is like a fading calcium.
Very true.
But stent boost I can appreciate much more better than
Ah.
routine cine.
40,
Baseline,
30 seconds.
stent
Then
boost, then if you can appreciate how much thickness it came down. I think now pitch change is not much.
Yeah, it's less. Madhyaka. Stop here. Shall we now try doing the imaging? We are going to glide assist mode. Samya, keep pushing the wire. Okay, take care. Push, 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 push. Yes. Now we do the imaging after crossing with the run-through wire. Initially, it was difficult to cross with the run-through wire, so we'll go with the microcatheter. Arya, ask Sharon to call Sharon. We are going with the microcatheter across the lesion. Is this a versatone wire or the run-through wire?
No.
Now the run-through wire. Run-through wire in deflator.
Okay.
Fourteen, 16.
Open channel.
Fluoro. Open cheyanda. Fluoro. Okay. Okay. Now we'll give some nitro and take a image and then do the OCT imaging. Sharath alla Sharon. ചെറിയ ഷൂട്ട് എടുത്ത് നോക്കിയാലോ ഫ്ലൂറോ okay we'll do an OCT pullback
put a second stand down
down there two overlapping അല്ലെങ്കിൽ long morph എങ്ങനെ എടുക്കേണ്ടി വരും മതി അവിടെ അവിടെ ചെയ്തോ ശരി we are ready with the OCT catheter. Joel,
yeah, and easily, yeah. Second lesion also we have crossed it.
we have crossed. Okay, 20 cc.
Right out of
yes. Guide is okay.
Guide
Okay.
is okay.
Now we are ready. Auto calibrate. Enable pullback. Activate. Okay. Now balloon. 2.75 or 3 distal. Vishnu, distal vessel size, how much is it? There, there. Yes, almost 2.9. We'll go with a 2.75 balloon. We'll go with a 2.75 balloon. Meanwhile, show us the image. Let's see what the orbital has done at their critical stenosis. And that's the distal lesion. That's the distal fibrotic lesion in the LAD. We'll see the proximal images. Come more proximally. Further more proximally. Proximally 2.7510. Yes. Proximally. Yes, that's the area where we did the. Okay, that's the area where we've done the. There we are seeing that calcified area that is almost 180-degree arc. Then as we come more proximally, can you show us more proximally? That area we see significant amount of sanding. Do we have any proximal lesion or that? That's the only area where it is. Here again we are seeing Vishnu, few frames distally. Yes, there again the calcium sanding has happened. It's been polished over there. Now furthermore proximally, these areas we see significant amount of sanding that has happened. I hope you can appreciate that.
It's effective sanding.
Yeah.
Deep gutter.
Yeah. That is very clearly seen. Okay, those areas also the calcium has been significantly shaved off. Arya Sharon. അടുത്ത പേഷ്യന്റ് എത്രയാവും അവനോട് നോക്കി പറയും. Melon seed. Yes. Again.
Slowly.
Now, Vishnu, what is the length from the LED ostium? Joel. Thomas K. file cost. Almost further distally, we'll go distally beyond. That's the fibrotic lesion. No, we'll position it just beyond that fibrotic lesion based on that angioco-registration. Proximally, it looks okay. We are near the ostium. The distal marker, no, cancel, tare, 8 on tare, cancel. Now, I'll Sharate co-registry. പുള്ളി അപ്പുറത്ത് കയറ്റിയ പമ്പ് അപ്പുറത്ത് കൊണ്ടുപോയി ചെയ്യാൻ പറ്റുമോ?
2, 4, 6, 8, 10, 12.
വേണ്ട, അതങ്ങ് ചെയ്തു തീർക്കാം. Balloon proximal lesion dilate ആയോ?
Only distally only. It was melon seeding. Now it's okay.
Okay. Okay. Now we'll come proximally and dilate it. Or else we'll take a longer balloon. Now I think it's opened up. Now proximally we'll dilate at higher pressures.
Yeah. 14, 16.
Or a 7.5 glove.
What is the length? 38.
Now we just second. Shall I move this side? So distally, this is actually the fibrotic lesion that we saw here. This is a fibrotic lesion. Now we go distally, we'll have it here. The distal landing should be somewhere here. Okay, we'll keep it here, and then proximally it is somewhere near the ostium. So it is almost 61. So we'll go with 2 stents. Thomas, we'll go with 2 stents.
Pardon?
2 stents.
Okay. Yeah. Sure.
Okay, 2.7538.
Yeah.
അവരോട് എത്രയാ പറഞ്ഞിരിക്കുന്നതെന്ന് ചോദിച്ചു. കോസ്റ്റ് തോമസ് കെ. So distally 2.7538 and proximally this areas the vessel size looks 3 plus. Near the ostium the vessel size looks again 3.5 at least. So proximally 3.5. Distal half we'll dilate with 3. Distal half we'll dilate with 3 post dilatation, 3 and 3.5 post dilatation. The distal stent will be 2.57538. Thomas, we've done proper dilatation, no?
Yeah.
Before stenting we'll do an OCT pullback and then go with the stent. Orbital the other side. We'll do an OCT pullback and then the stent. Joji alla Thomas KV. Joji here, Thomas KV the other. cc sir. We are going with the OCT catheter. Live view.
Sorry.
Okay, we are ready with the OCT catheter. Auto calibrate. Okay, we are ready. Yes, enable pullback. Activate. Give us the stent. 2.7538 distally and 3.5 proximally. 2.7538. Vishnu, we are seeing some breaks there in that particular area where, Vishnu, you can explain.
This, where the sanding happened,
Thumbs.
there is a crack is there in that area, gutter. And there is a deep dissection, deep intimal dissection.
In the previous area, exactly the place where we had that gutter, exactly there we have seen the fractures. That is the area where we have the thinning of calcium. We are seeing fracture at 3 o'clock position. 3 o'clock position. I hope you can appreciate that.
Yes, calcium become weakened.
Weakened, yes.
Become dissected by visa balloons.
Yes. Dissected and fractured. Vishnu, please go. അവിടെ 7 New York.
Fibrotic area. In distal area, the diameter is
before that muscle bridge will look shoot. They almost cut down for the
Thomas Key.
like this 60.
Huh?
This is fine, no?
Initially we are taking 2.75.
Yes, that looks good.
Into overlap with
1 millimeter distally.
28.
Yes, we'll go up. 12, enough. Negative. We'll pull the balloon couple of millimeters back and go at 16, 18.
Yeah.
Okay, 18. Now we'll decide on the proximal stent length.
Distal is 2.75 to 38.
Yeah, distal is 2.7538. Proximally, it should be almost half of that. Cine. 28 would be enough. 28, 3.5, 28. 3.5, 28, and then distally we'll post dilate with 3 and proximally we'll post dilate with 3.5 and then do a final OCT pullback.
Lower down 6 o'clock is a cut or
at 6 o'clock position, it's more of we could call it as a fracture also, because there the calcium is almost getting over at that particular area, and that could be a fracture and then dissection. At the edge we are seeing a dissection. That's the area where we have a proper sanding also being done. Probably at 12 o'clock position it's more of a dissection. If you move the frame forward and backward, will be much more clearer. Yeah, now that's a dissection only. It's a dissection with that fracture there at the calcium. Okay. Whatever said, and then we'll have to cover that with that stent. Come caudal, come caudal. Anyway, distal overlap is good. That looks good. Cine? Yes, perfect. 12. 12. 3.5 28. Negative.
Okay.
Come caudal and show the circumflex ostium. Small test. Yeah, the circumflex ostium looks good. Now we'll post dilate with 3 and 3.5. 3 and 3.5 and final OCT. The plaque has been.
We can appreciate OCT. I think the distal stent is just near that muscle bridge.
Almost. But there is no severe systolic milking, but then it seems as if it's dipping into the myocardium.
20 from why small balloon 380. Okay.
Smaller balloon, huh?
Why small? I'm just saying. Cranial, Jojo. Why short balloon 380?
Better pressure and better reusability.
So this is the OCT image. What is it in the 1 o'clock position?
Cranial.
Come cranial. Microvasculature. One millimeter back. It's a 3 balloon. Yes.
Oh.
14. Negative. Okay, 14. Negative. 16. Negative. 18. Beyond there, we'll go with a 3.5. Okay. Negative. Now we'll take a 3.5 balloon and final OCT pullback. .5. After this, we'll have Joji here. Joji.
Per angioplasty, you do minimum 3-4 OCT runs. Preparation, first decision making, then preparation, then post-stent optimization.
Yeah. When you look at the October bifurcation trial, they have suggested at least two runs, right? That is after preparing the lesion. Initially, if you're not able to cross the lesion with the OCT catheter, prepare the lesion and then do an OCT evaluation. Make sure that you prepared the lesion well, and make sure of the landing zones, the length, the diameter. Go ahead with stent implantation and finally for optimization. So at least 2, right?
Yes.
Is it correct? For the October, that's how they've done.
Yeah. Yesterday only ESC guidelines, they made class 1A indication.
Yes, imaging. IVS as well as OCT.
OCT, intravascular imaging.
3.5? Okay.
3.5.
Sharon?
Wait. It is getting stuck here.
അവരോട് ചോദിച്ചില്ലേ? ജിനേഷിനെ വിളി.
Caudal.
Come caudal.
20.
Small test. Yes. Yes. 14, 16, 18. 14, 16, 18.
We got the
കുത്തിയില്ല ഇതുവരെ കുത്തിയില്ല. We should finish the orbital there and bring the pump over here for the next case. Finish it.
Ostium is fine, no?
Now we'll do an OCT pullback. അതിലില്ല, അവർ റിലേറ്റീവ്സിനോടൊന്ന് സംസാരിക്കണം. എത്രയാ പറഞ്ഞിരിക്കുന്നത്? ഞാൻ എത്രയാ പറഞ്ഞു? ചുമ്മാ ഫയലില്ല, നമ്മ എടുത്തോണ്ട് വന്നു. അതില്ലാന്ന് ഇവൻ പറയുന്നത്, അതിലില്ല. Okay, now we'll do an OCT pullback and final images following that. Good, looks good.
It is not significant.
Yeah, circostium looks reasonable. No significant. Okay, we are going with the OCT catheter. Ready there? Show the live view. Okay, then freeze. Come cranial.
Small lesion.
Oh, we need to be careful with that. When we take it out, we need to take it together, the wire, because okay, we'll do the imaging. We'll do the imaging keeping the catheter there. Okay. Yes, live view. Okay. It's inside the stent, but then we don't want to push. We wouldn't want to push it further distally because it's not inside the wire. Okay. It's fully purged. That looks good. Not an issue. Okay. Yes. Okay. Enable pullback. Activate. Now when you see the wire like this, it's always when you pull it back, pull back the wire as well as the imaging catheter together. Otherwise it will buckle on the wire and then you would find it difficult to pull it back. So pull the wire as well as imaging catheter together. Then once we are okay, we are almost done, so we'll take it out and take the final post nitro images. Nitroglycerin, caudal and cranial. See if the expansion is good. If the expansion is not good, we'll have to rewire it, but then
this will expand at a post.
Vishnu, what about the expansion?
I'm just covering the LED ostium. Once that is
and we'll see the LED ostium in the bifurcation image also to see whether the positioning of the stent is bifurcation, 3D bifurcation. Yes. Last cranial image. Okay, that looks good.
Very good. Extraordinarily good result.
Okay, now you enlarge the OCT image. You can see that the positioning is also perfect. It's just one strut at the left main across the circumflex ostium. Can you just move it forward, move it and show? No, there, not there, on the top, yeah, so that we can see the ostium very clearly. You can see now the circumflex ostium very clearly, just that one strut into the left main, well positioned. And what about the expansion also? Is it the luminal areas? Proximal vessel looks 7, proximal area looks 7, distal it should be at least 5. It's 5, 5.5. That, yeah, that looks good. I think we'll call it a day.
Everything is above 5.
Yes. Now, can we have some discussion for around 10 minutes or so? Vishnu, your presentation for 10-15 minutes. Meanwhile, we'll get the next case ready. Your presentation we'll have. Sharath?
So this non-left main more than 5 is a good result, or 4.5 is it?
4.55, anything is okay. With IVUS 5.5 and with OCT it's 4.5. We'll be happy if we have at least 5 millimeter. When we do a drug-eluting balloon, no, for instant restenosis, at the end of the day, if you have 5 millimeter lumen, that's good.